Good morning, everyone. And today, this is the second lecture of neurology, and today we are going to discuss start with the cranial nerves. And again, this is just a part of introduction because, of course, this is like the basic sciences. Basic neurology. And as I told you yesterday, um, cranial nerves. Of course, like in neuroanatomy, they teach us all the functions of the cranial nerves and where they are located. So. There is 12 cranial nerves. As I told you, you have to remember the names in sequence, okay? In the same sequence. Why? Because when we go in clinical examination, we examine the cranial nerves in the same sequence: olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, or spinal nerve, and hypoglossal. You can see over here, this diagram is of course just to showing you that this one is the olfactory nerve, then there is optic nerve, of course, they cut it short just to show you, and then there is what you can say, oculomotor, you can see over here, then trochlear, and so on and so forth. Many people find it very hard to remember, from where all the cranial nerves they arise from. Guys, it's very, very, very easy. The last four nerves, okay, the last four nerves, they arise from the brain stem, okay, medulla and the pons. The middle four nerves, which is like the trigeminal, abducens, facial, and vestibulocochlear, okay, they arise from the what you can say. See this one. See this is like the vagus, okay. This is the hypoglossal, okay, and all these ones. So they arise from the midbrain, okay. These nerves, you can see the trigeminal and all these nerves, and these four nerves, okay, they arise above them. So it's very easy to remember, from where the nerves arises. So simply, this one is like they're showing the brain from the down, but the important things to know is to remember the names in sequence, because when we clinically do examination of the nerves, we do it clinically in the same routine. Again, this is a chart which is showing the name of the cranial nerves, their numbers, their functional categories, and their functions. So like olfactory nerve is a complete sensory nerve, okay. Of course, it's carry a special sense. As you know, there are general senses and there are special senses, like the taste, hearing, vision, and smell. They are the special senses, whereas the touch, vibration, and all these ones are called as the general sensations. So optic nerve, again, they carry a special sense, which is vision, so it is also a special somatic sensory nerve. Oculomotor, you can see it is a motor nerve, somatic motor nerve, but it also carries the parasympathetic fibers to the pupil. And whenever the optic nerve, whenever these fibers are stimulated, it causes, you can say, the constriction of the pupil. Whereas the sympathetic supply, whenever it is innervated, it is activated, of course it is going to cause the dilation of the pupil. Same thing with the trochlear, it is the motor nerve. Trigeminal have sensory as well as the motor supply as well. Sensory, of course, it carries all the sensations. See, it's written general somatic sensory, not special. Why? Because the trigeminal nerve is the one which carries the general sensations like pain, temperature, touch, okay, vibration, and all this one from the face. So remember, special sensations are vision, uh, audition, like hearing, smell, as well as taste, okay. So the motor part is basically the muscles of mastication and tensor tympani muscle, which is supplied by the trigeminal. Abducens, which is the sixth cranial nerve, it is motor nerve, and it supplies the, remember the formula, LR6SO4. Very, very, very easy. I remember this thing, when I was in medical school. Till today, I'm using the same formula, LR6SO4. Okay, so LR6SO4, if you know what you can say, LR means lateral rectus, okay, and SO4 means superior oblique. So LR, lateral rectus 6, means 6 cranial nerve. So this one abducens, it supplies the lateral rectus muscle. SO4, superior oblique. SO, superior oblique 4, fourth cranial nerve. So superior oblique is supplied by the fourth cranial nerve. So leave LR6 SO4, which is lateral rectus, is supplied by the sixth cranial nerve, and SO4, superior oblique, is supplied by the fourth cranial nerve. Rest all the extraocular muscles are supplied by the third cranial nerve. Very, very, very easy to remember. Okay, remember LR6 SO4. So what it means? Lateral rectus is supplied by the sixth cranial nerve. SO4, superior oblique, is supplied by the fourth cranial nerve. So leave LR6 SO4. What are the rest of the extraocular muscles are all supplied by the third cranial nerve. Okay, so all the extraocular muscles except the superior oblique and lateral rectus. So to remember that these two muscles, remember LR6 SO4. And the third cranial nerve also supplied the levator palpebrae superior. Okay, but like I found it very easy to remember. I don't know like how you guys are going to take it, but like this one is the easiest way to remember this one. So this is the thing. So after that, guys, there is facial nerve, and facial have the motor part which supplies all the muscles of facial expression, as well as the parasympathetic fibers it carries, which supplies the lacrimal glands, submaxillary, submandibular, salivary glands, and then it have special sensory fibers which carries the taste sensation from the anterior two-thirds of the tongue. Okay, so this thing, and then it also have general somatic sensory. So it carries a sensation from a smaller region near the external auditory meatus. Okay, so it carries special sensation. It carries general sensation. Okay, so again, easy to remember, I think. Not so hard thing to remember. Okay. And now, other than this, there is vestibulocochlear. Of course, vestibulocochlear carries special sensation. Hearing. Okay. This one carries special sensation, which is the hearing. So remember this thing. You know the origin of the nerves. As I told you, very easy to remember, guys. The first two cranial nerves, basically, they are attached to the cerebral hemisphere. Okay, the first two cranial nerves, they are attached to the cerebral hemisphere. Basically, they are not the true cranial nerves. That is another discussion, by the way. And then, what is left, if you will take out the first two cranial nerves, what is left is these 10 cranial nerves. So, first two cranial nerves are attached with the cerebral hemisphere. Next two arise from the midbrain. After that, these four arise from the pons, and the last four arise from the medulla. Okay, so very, very, very easy to remember. Not a big science. So this is like how we can remember the origin of these nerves. Then there is glossopharyngeal nerve. It have motor fibers which supply stylopharyngeus. There is a formula to remember this thing as well. You know, all the muscles, pharyngeal muscles of swallowing, is supplied by the vagus nerve, except one muscle. And why that muscle is not supplied by the vagus nerve? Because that muscle is have a style. Okay, and you know, to bring style, you have to apply some gloss. So glossopharyngeal supply the stylopharyngeus muscle. Rest all the muscles are supplied by the vagus nerve. So glossopharyngeal also carries the parasympathetic fibers which supply the parotids. General sensations from the middle ear region. Okay, special sensations from the posterior one-third of the tongue. Taste sensations. Okay, so simply and also, you know, it carries visual sensory, but general chemo and baroreceptor of the carotid body. So the taste sensation from the anterior two-third is carried by the facial nerve, and the posterior one-third it is carried by the glossopharyngeal nerve, and the taste sensation from the epiglottis and the pharynx is supplied is carried by the vagus nerve. See, the vagus nerve, the motor part supplied all the pharyngeal muscles, which is doing swallowing, and the laryngeal muscles of voice box. It also carries parasympathetic fibers to the heart, to the lung, and to the digestive tract. If you know, like the vagus nerve, it goes all the way down to the abdomen, to the chest, and it supplies all the parasympathetic nerve fibers to the heart, to the GIT. So, uh, this thing, general somatic sensory sensation from pharynx, meninges, small region near the external auditory meatus. External auditory meatus is very, very, very complicated. You know, many of the nerves they carry sensation from this part. Special sensation it carries from the epiglottis as well as from the pharynx. Okay. Then there is spinal nerve or a spinal accessory nerve, which is completely motor. It supplies the muscles around the neck, sternocleidomastoid, and the upper part of trapezius. And hypoglossal muscles is again motor, which supplies all the muscles of the tongue. Okay, very easy to remember. Like I don't think so. I don't found it hard to, you can say, to remember. Like the names and from where they originate. Okay, so not hard to remember, guys. Okay, this one is like the classification of the cranial nerve nuclei into the motor and sensory columns. If you will see it again, like what are the location of the nuclei. Okay, so if you can see in this diagram, in this table, sorry, uh, this one, which is in front of you, you will found that the functions, okay, and where are the nuclei, and these are the name of those cranial nerves. These are all the motor nuclei. These are all the sensory nuclei. Okay, and where they are located. Uh, like this table which I'm showing you here, I will suggest you better to see some atlas like Clement or Netter's atlas, just to know. And basically, there is no point to say the names of Edinger Westphal nucleus or what is salivary nucleus or what is nucleus tectum and all this stuff. Why? Because if you don't know the functions, if you don't know the anatomy in detail, of course, like there is no point to go in detail. Okay, so move forward. By the way, I was just waiting, like, because this is too much information, but like you can pause the video and see it if you want to take a look. So see, there is 12 pairs of cranial nerves. Okay, like of course because pairs, because one on each side, on the right and the left, and some of them they are sensory, some of them they are motor, some of them they are mixed, as I show you in this one and this one. Okay, I will not suggest you, because it's very hard to remember this mnemonic, to remember the names of this. And why I'm saying you again and again why it's important to remember them in sequence, guys, because when you do clinical examination you go in that sequence. First of all, we ask the patient, for example, to, like, we don't generally bring something under the nose to ask them if they can smell this thing. But like at the start of the examination, we generally ask, like, right, is there any problem with the sense of smell these days you have or not? And then we go to examine the eye muscles, like eye movements. We see simply how the pupils are either reactive or not reactive, and we go in this way. Okay, then we check their face, we check the sensations, and simply. Like I told you, geeky medics like try how they classify, how they examine the cranial nerves, then you would know like why I'm saying to remember these things in sequence. Okay, so first cranial nerve, you're just supplying the nose. Second one and the third nerve. Second nerve, of course, it is the optic nerve which supplies the retina. Third one, extraocular muscles, as well as the muscles for the lids. Fifth cranial nerve supplying the sensation. Sixth one again supplying the extraocular muscles. Sixth one, LR6, lateral rectus. Seven one supplying the muscles of facial expression. Eight supplying the vestibule and the cochlea, nerve of the hearing and balance. Nine one is which one? Glossopharyngeal, supplying the stylopharyngeus as well as the what you can say taste sensation from the posterior to one third of the tongue, and then there is what you can say the vagus, which is the longest nerve you can say, going to the ear, going to the pharynx and the larynx, and going to the heart and lungs and all the GIT. And then there is spinal accessory nerve, which is going to the sternocleidomastoid as well as the trapezius, and then there is hypoglossal nerve, which is supplying to the muscles of the tongue. First two are attached to the cerebral cortex. The next two are arising from the midbrain. Okay, and then the other one, they're arising from the pons, and then the last four, they are arising 1, 2, 3, 4, arising from the medulla. These are the mnemonics. On old Olympus towering top, a famous vocal German viewed some hops. Very hard. I remember easy one, by the way, but that is a bad mnemonic, of course. I don't want to say it here because I don't know like who else will see this video. So, of course, like you can Google that and found many bad ones if you want. Okay, guys, like I'm not going to talk in detail about the cranial nerves. Of course, like they are going to just waste the time, and like of course, I will scroll it down so that you can see these things. Of course, cranial nerve one is responsible for the sense of smell. Okay, and whenever it can be damaged, there can be anosmia, absence of the smell, or hyposmia or hyperosmia or parosmias, things like this. Foster Kennedy syndrome is typically caused by meningioma. The tumor of the meninges includes anosmia, optic atrophy in one eye, and papilledema in the opposite eye. Cranial nerve 2 is optic. This is the one which is carrying the sensation from the retina, and this one is the most complicated nerve. These are the eyeballs. These are the optic nerve. The fibers from the, okay, see, this is our skull, so this is the temporal side. Here there is nose, so there is nasal side of retina, there is temporal side of retina. Now the nasal side of retina basically is viewing what is on your peripheral side. For example, when I'm looking straight, and if I will talk about my left eye, for example, so the fibers which are on the nasal side towards the nose, they are catching or getting the rays or the sight from my left side, whereas the fibers from here which are on the temporal side, they are giving me view on of my right side. Okay, so see, these fibers which are coming from the nasal side of the retina, they cross over and go onto the opposite side. But whereas the fibers from the temporal side, they remain on the same side. Okay, what it means, guys, see, the fibers which are from this temporal side of this side and the nasal of this side are going to go on the same side of the brain, whereas the fibers which are from the nasal side of the left eye and the temporal side of the right eye are going to all cross over and go onto the right side of the brain. That's why, for example, if someone is going to cut the nerve on this side, what will happen? All the vision will be lost in the eye. This eye will be normal. But if the fibers will be cut at this place, so the fibers which are coming from the nasal side of this eye as well as the temporal side of this eye are going to cut off. And the patient will be having what? Bitemporal hemianopia. What it means, the patient cannot see, will have a bad vision on the sides. Just he will be seeing something towards the nasal side. Okay, what it means, the patient will develop a tunnel vision, like you're going through the tunnel and you can see just something in a tunnel type of view, right? But if someone will lose the fibers from here, okay, so which fibers are going to be cut? See, all the fibers from the nasal side of the left eye and all the fibers which are on the temporal side of the right eye, and the patient is going to lose the vision on one side. See, there will be no vision here and here, so they will be having contralateral, on the other side, homonymous hemianopia. So this one is like a very, very, very complicated type of tract. Okay, we call this thing as optic nerve. This is optic chiasma, and this one is optic tract. Okay, um, I think, like, when you will have a chance, you can go see some lecture. You can open your books and see how the optic nerve carries the sensations of vision to the brain, to the visual cortex, which is in the occipital lobe. Okay. So whenever we have to check the second cranial nerve, what you can check, see, it is related with vision. So what we can check is visual acuity. If you had been to ophthalmologist, what they do, they put a Snell's chart in front of you, and uh, they can check your vision. Either you can see that, or either you cannot see that. Also, now there is a big circuit going on in the eye. Of course, like, I don't have that thing over here, but the important thing, if I can found, let me check, if I can found right now without wasting much time. Okay, I don't have that thing here. Basically, the optic nerve, it carries it is supplying the retina. So when we throw light by the help of torch on retina, what happens, that the sensation is carried to a nuclei in the brain, and that nuclei again send fibers through other nerve. Okay, um, you can say, to the pupil, and it causes constriction of the pupil. Constriction of the pupil is done by parasympathetic fibers, which are carried by the third cranial nerve, right? So uh, that's the reason, guys, when we sorry, like, I was talking about the second cranial nerve and the slide was for the third cranial nerve. So we call it as light reflex. Okay, and there is direct light reflex as well as consensual light reflex. If we are throwing the light in the right eye and we are seeing, like, how the pupil is going to react in the right eye, it is called as direct light reflex. Okay, but when we are throwing the light in the right eye and see how the pupil is reacting in the left eye, because there is a connection in the brain between these two sides, so it is called as consensual pupillary reflex, or indirect light reflex. Okay, so that thing which we can check. Okay, so this thing is what you can say is called as direct light reflex, or the relative light reflex. Okay, so we can do this thing. Other thing, we can do fundoscopy in these in the like in these when we are examining the second cranial nerve. Fundoscopy, of course, we can check the optic disc, like either there is any edema or there, which is called as papilloedema. For example, in cases of increased intracranial pressure, we can see that, or for example, in the case of optic neuritis, when there is inflammation of this nerve. So we can check this fundoscopy. Okay, we can check the condition of retina by fundoscopy, checking for any diabetic changes, any hypertensive changes, any hemorrhages, any flame hemorrhages, any you can say aneurysm formations and all this fun. You can also do color testing. Many people, they are color blind, guys. So in that case, of course, we can use some special plates called as Ischia charts and stuff like this. So uh, this thing, then we can check the eye movements. Okay, so of course, like these, they are showing, how which muscles are supplied by which cranial nerve. Okay, lateral rectus is supplied by LR6 with sixth nerve. Okay, and superior oblique is supplied by the fourth cranial nerve, and rest all are supplied by the third cranial nerve. So lateral rectus is supplied by the sixth, superior oblique is supplied by the this one by the fourth, and all the others are supplied by the third cranial nerve. So we check the eye movements. Okay, so we check extraocular movements simply in a H-shaped manner, when you will see, of course. Third cranial nerve also supplied the muscle, levator palpebrae. So when the third cranial nerve is gone, of course, what is the thing is, there can be ptosis or droop eyelid. We can also see the shape of the pupil, because the third cranial nerve also carries the parasympathetic fibers to the pupil, which causes constriction. So this one can be checked. Third, fourth, and sixth cranial nerve are checked together, because all of them, they supply the eye. So these are the pupil abnormalities written over here, like what is Addy's pupil, like in which the pupils are giving sluggish response. What is Argyll-Robertson pupil? Okay, of course, like there is big pathologies behind that. What is Addy's pupil is called as Holmes-Addy pupil, the full name, and Marcus Gunn pupil. Reduce efferent input in the affected eye. Pupils fail to constrict fully. Okay, so this thing. There is something called as Horner syndrome as well, in which the person, they have absence of sweat on that side of the face, as well as with what you can say, the pupils are what you can say, are smaller in size. Why? Because the sympathetic supply to the pupil is gone. In that cases, that is called as Horner syndrome. So caused by loss of sympathetic innervation to the eye. Okay, that is Horner syndrome. Squint you can check in these patients, of course. Abducens is the sixth cranial nerve, and which supplies sixth cranial nerve, which supplies the lateral rectus. Okay, so once you have checked this thing, see what they're trying to show here. Of course, like when the patient is looking on this side, of course, lateral rectus is the one which is taking the eye on this side. Then we check the trochlear nerve, trigeminal nerve, which is the fifth cranial nerve. It carries the sensation of pain, touch, and all this one from the all over the face. It have three divisions: V1, V2, V3, or ophthalmic, maxillary, and mandibular. Okay, shown over here. This is the ophthalmic. It carries the sensation from this part of the face, maxillary, and mandibular. So we check the sensation in this part, in this part, and then in this part. Okay, and then we also check the muscles of mastication, because they are also supplied by the fifth cranial nerve. Okay, you can also do a jaw jerk, because that is also carried by the same nerve. So this thing is done. So then we go for what you can say, seventh cranial nerve examination. This is the nerve which supply the first muscles of all the facial expression. So we ask the patient to look up without moving his head. Like they move their eyes, we see the forehead creases. We ask them to close the eyes and don't let us open that. We ask them to close the mouth and don't let us to open that, just to check either the facial nerve is working properly or not. Okay. And also, by the way, clinically we don't do this thing, but if needed, of course, if you're just examining the facial nerve, so you can check the taste sensation in the anterior two-third of the tongue, of course. Okay. And you can also like, of course, it also give parasympathetic fibers to the lacrimal gland and the salivary glands. You can have a look at the eyes or the mouth just to see, either there is secretions are there or not, though we don't do it clinically. So whenever there is, whenever there is problem with the facial nerve, what happens is, like, there can be ipsilateral or like loss of what you can say facial expressions or facial muscles. Loss of lacrimation can be there. Decreased salivation can be there. Saliva will be formed less. Dry mouth simply. Or loss of taste sensation in the anterior two-third of the tongue. Ipsilaterally, of course, can be there. One very important thing, guys, like I would like to mention here is very, very, very important thing. Wait, I will show you. Sorry, just trying to find a better diagram for that. I have a slide, for a facial nerve completely. I will try to explain this thing here. It's very important to understand. Very important to understand. When I will teach you what is upper motor neuron type of lesion and what is lower motor neuron type of lesion, you would understand this thing in a better way. But for now, facial nerve, which is the seventh cranial nerve, okay. See, it is originating from the brain, okay, and see, if you will follow this purple one, okay, this purple one, which is innervating the lower half of the face, facial nerve. So it is entering into the brain, and from there, the second order neuron, these are the third order neuron, the second order neuron are going all the way up, and then of course, like, there will be first order neuron, and they are going all the way up to the cerebral cortex, right? Whereas the fibers which are from the which are innervating the forehead, see, they are going and they are entering into the brain, and see, they are connecting with two other neurons. One is going on the same side of the brain and the other one is going on to the other side of the brain. What it means? Simply, our right side of the cerebral cortex is controlling the left side of what? Of the lower half of the face. But if we will talk about the forehead, the control is coming from both sides of the brains, right and left. Okay. For example, someone facial nerve is cut at this level. Okay, what will happen? All the muscles of facial expression will be lost on the same side of the brain, of the face. But someone who have an upper motor neuron type of lesion, for example, a stroke, and the problem is in the cerebral cortex, you can see over here, they are showing here. Which lost will be there? See, no connection, no impulses will go down from here. So the person is going to lose the muscles of facial expression in the lower half of the face, but the upper half of the face will still be intact. You can see lesion A, which is at this stage, because the fibers which are controlling the muscles of facial expression or the forehead muscles, they are getting innervation from both sides of the brain. So when they have lose the innervation which is coming from the right side of the brain, but they still have the innervation which is coming from the left side of the brain. Okay, so I will say just one line, and you can learn it in more detail. You will understand this thing in more detail. Very, very, very important concept to learn. Whenever there is upper motor neuron type of lesion, related to the facial nerve, okay, facial innervation, the person will be having forehead sparing. Why? Because this one is getting innervation from both sides. But someone who have a lower motor neuron type of lesion, when the nerve is gone, they will lose the control or the muscle of facial expression of both the lower half of the face and the upper half of the face. When I will discuss the lower motor neuron type of lesion and upper motor neuron type of lesion, I will discuss this thing again just to put this thing in your mind. Okay, so in lower motor neuron type of lesion, there will be ipsilateral facial weakness. Okay, ipsilateral facial weakness. But in upper motor neuron type of lesion, there will be contralateral facial weakness sparing the brows or sparing the forehead. Okay, very important concept to learn. So if we'll go further, this is like when I will discuss, facial nerve. I will explain you more. Okay. Bell's palsy, of course, we'll discuss like someday. Okay. Okay, yes, this thing is important. I forget to tell you, like, what is this? Corneal reflex. Okay. What is corneal reflex? When we are going to touch the cornea by a cotton bud, what happens is, like, our eyes get blinked. Okay. So corneal reflex, the afferent limb, in corneal reflex, the afferent limb, or the nerve which is carrying the sensation to the brain, is done by trigeminal nerve, the ophthalmic division, V1. The afferent limb starts at the facial nucleus and travels by the facial nerve to innervate the orbicularis oculi muscle that close the eye. Okay, and that lead to the blink. So loss of the trigeminal facial nerve nucleus or facial nerve may loss in the corneal reflex. Okay, so that is like we can check the blink reflex or corneal reflex. Okay, just to check like either there is any problem with the facial nerve or not. Guys, the eighth cranial nerve is the one which is called as vestibulocochlear nerve. It has two parts, vestibule part and cochlear part. Vestibular part is the one which cochlear part is the one which carries the what you can say, the hearing, and vestibule part is the one which carries the balance things. So whenever there is any problem with this nerve, of course, like we can have sensory neural hearing loss, we may have vertigo, we may have nystagmus, we may have disequilibrium. Okay, again, when we will discuss like what is hearing loss, we will discuss that thing in detail as well. Do watch a video, how we examine the cranial nerves. So basically, when we do what you can say, the hearing test, what we can do is, one thing is called as Weber's test and one thing is called as Rennie's test. They are done by the tuning forks. Okay, so anyhow, then comes the glossopharyngeal nerve, which of course, like I told you, it carries the taste sensation, it supplies the vocal cord, stylopharyngeus muscle. Okay, this is the one which causes the gag reflex as well. When you touch the back of your mouth, we do gag like this, so that is a gag reflex. And whenever like this nerve is damaged, we lose the taste sensation in the posterior posterior 1/3, sorry, of the tongue, ipsilateral side, of course. There is a loss of gag reflex as well. There is dysphagia, and though unilateral lesions are rare, but of course they can occur. We will discuss like bulbar palsy and pseudobulbar palsy in detail, of course. Like vagus nerve, in physical examination, what we do, like we assess the vocal cord functionality. We examine the gag reflex. We ask the patient to open the mouth, and we see the position of uvula, the hanging in the middle of the back of your mouth, uvula. So we see like either it's deviated on any side or not, and we also assess the swallowing, either the patient can swallow or not. Because whenever there is any problem with the vagus nerve, there is loss of gag reflex, there is dysphagia, difficulty in swallowing, there is hoarse voice, there is paralysis of the soft palate, and there is deviation of the uvula, of course, to the contralateral side of the lesion. Okay, and there will be loss in the sensation around the pharynx and larynx ipsilaterally. So, see, normal palate looks like this when we ask the patient to open the mouth. But whenever there is paralysis, it is deviated. The uvula is deviated. Okay. And whenever there is bilateral paralysis, what happens? Like all these muscles, they go down. So see, the uvula is deviated contralaterally on the opposite side. So then there is spinal accessory nerve. It is a motor nerve. It supplies the trapezius muscle by which we shrug the shoulders, and it also supplies the sternocleidomastoid by which we turn the head, trapezius, the red parts, and sternocleidomastoid. So this can simply be ask the patient to shrug the shoulders and try to push them down, and ask the patient to look on one side and try to press it and assess like how what is the bulk and power of the sternocleidomastoid muscles. And then come the hypoglossal nerve, which of course supply the muscles of the intrinsic muscles of the tongue. So we have to inspect the tongue, of course, for signs of any lateral deviation, for signs of any atrophy, for signs of any fasciculations, any asymmetry of the movement, to assess the strength of the tongue. So when we found any wasting on this any side of the tongue, or ipsilateral wasting, or of course like we can also see like if there is any deviation to the of the tongue to any side, we ask the patient to protrude his tongue, take out the tongue. Okay, and we see this one, unilateral tongue paralysis. The tongue is deviated. Why? Because the muscles are lost on this side. Okay, so wasting of the ipsilateral tongue muscles and deviation on the same side. Okay, on protrusion. But when there is bilateral paralysis, of course, that bilaterally the tongue will be atrophic, and of course there will be no deviation because the muscles are weak on both of the sides. Okay, so this is like the examination for the hypoglossal, what you can say, hypoglossal nerve. So like this one is like to show the general tactile sensation as well as the special sensation. Special sensation from the tongue, anterior two-third by the facial nerve, posterior one-third by the glossopharyngeal nerve, and there are taste fibers, by the way, taste receptors in the pharynx and larynx as well. So that is supplied by carried by the vagus nerve, and these are the general sensation from the tongue. What it means when you are eating something, okay, and when you are enjoying your food, okay, so that beautiful enjoyment of the food, the sensations of that taste is carried from the anterior two-third by the facial nerve, and from the posterior two-third of the tongue by glossopharyngeal nerve, and all the sensations which are coming from your throat or the pharynx part and the larynx part is basically carried by the vagus nerve. But while eating, when you feel the food on your tongue, not the taste, the feel of the food, if there is any bone or something prick your tongue, that is carried by trigeminal and the glossopharyngeal, the general sensation I'm talking about. For example, while eating, when you are grinding the food, chewing the food, and you bite your tongue, this nerve come into play. I hope you understand. This example is very good. Okay, so that's how is the innervation of the tongue. Special sensation as well as the general sensation. Okay. Okay. Because this one is written over here, I think we will do this thing and we'll finish that. Bell's palsy and all the facial nerve I'm going to discuss in more detail when I will discuss upper motor neuron type of lesion as well as lower motor neuron type of lesion. Cranial nerve 9, 10, 11, and 12, which is basically which nerves? Glossopharyngeal, vagus, accessory, and hypoglossal. Damage to these nerves is very common type of CNS injury. Okay. Whenever the vagus nerve is damaged, hoarseness is the thing. Okay. For example, in lateral medullary infarct, because the nuclei is present over there. Dysarthria or articulation. See how we produce, like how I'm talking, like I can produce a sound like ah, okay, like this. If I cannot produce this sound, it is called as dysphonia. And then the language, the comprehension, and all this stuff is in my brain, what we call it as language, by which we comprehend and we understand the language and all this stuff. If someone lost that, it is called as dysphasia, not dysphagia. Dysphagia is difficulty in swallowing. Dysphasia, PHASIA. And I am articulating things by the help of my tongue, by the help of my lips. If someone have problem in that articulation, that is called as dysarthria. So there is phonia, there is phasia, there is arthria. So this arthria is abnormal articulation of speech. Can occur from injury from cranial nerve 5, 7, 9, 10, and 12. Why? Because these are the nerves which are used to move our mouth, our tongue, our pharynx, our larynx. Okay, we articulate the things in our tongue, of course. So whenever like there is damage to any of these nerves, we cannot speak properly. And dysphagia, which is swallowing, this can occur whenever there is damage to any cranial nerve like 9, 10, and 12. Simply glossopharyngeal, vagus, and hypoglossal. Okay. Brainstem nuclei involved in laughing and crying include cranial nerve 7, 9, 10, and 12. Okay. So whenever there is lesion of corticobulbar parts in the subcortical white matter, I don't know how many of you are getting it. That's why neural anatomy is important. Can cause pseudobulbar effects in which patients exhibit controllable outburst of laughing or crying. Okay, with no accompanying emotions. Okay, guys, what is bulbar palsy? Now, when there is bilateral impairment of function in the 9th, 10th, and 12th cranial nerve, which is the glossopharyngeal, vagus, and hypoglossal, there is clinical syndrome of bulbar palsy. And what happens in bulbar palsy? There is dysarthria, we cannot articulate properly, dysphagia, we cannot swallow properly, and dysphonia, we cannot produce the sound properly. And there is a poor cough, like not like but like this, okay, because of the weak vocal cords. And these are the people who are susceptible of aspiration, which can lead to aspiration pneumonia. Okay, so we collectively call these features as bulbar palsy. See this one. So like they're just showing, palate, larynx, pharynx, and tongue. Like these are the conditions like which can affect these areas, like syringobulby as a condition, skull base tumors of the skull base, and Guillain-Barré syndrome, or recurrent laryngeal nerve palsy, or myasthenia gravis, which can cause damage to these parts. Now, what is the difference between bulbar palsy and pseudobulbar palsy? Bulbar palsy is a lower motor neuron type of lesion in which the damage is to the nerves. Okay. Pseudobulbar palsy is when the damage is in the central nervous system. Well, you know what is central nervous system and what is peripheral nervous system? Anything in the brain or in the spinal cord is called as the central nervous system, and any structure which constitute the nerves, it is called as the peripheral nervous system. So pseudobulbar palsy is central type of damage, and bulbar palsy when the damage is to the peripheral nerves or the nerves, cranial nerves, right? Okay. Now, the difference between bulbar palsy and pseudobulbar palsy is what can be seen over. Okay. See, in bulbar palsy, the cranial nerves are damaged. So the presentation is that, okay, again, you will understand this thing better, or you have to correlate again what I'm saying, like in the next lecture when I will talk about the upper motor neuron lesion and lower motor neuron lesion. In bulbar palsy, then, like, of course, after that, you had a very good concept about this thing. See what is going on in lips in bulbar palsy, which is the damage to the cranial nerves. Tongue is weak and wasted, and it have fasciculations. There will be drooling of saliva in the mouth, and the patient is unable to swallow. There is absent palatal movement. There will be dysphonia. There will be articulation problem. They have difficulty pronouncing R. Now, if you will see pseudopulpal palsy, the tongue is paralyzed, but there is no wasting and there is no fasciculations. Okay, and they will be having more Donald Duck type of speech. Palatal movements will be absent, dribbling presently. Facial muscles may also be paralyzed. Reflexes are exaggerated. Okay, and there is nasal regurgitation, dysphonia, dysphagic. Okay, and there may be neurological deficit in the limbs, for example, increased tone, enhanced reflexes, and again, it needs the understanding of what is upper and what is lower motor neuron type of lesion in the next lecture. Then, when after knowing what is upper and what is lower motor neuron type of lesion, then you will understand this thing properly. Okay, these are some cranial nerve syndromes, guys. For example, there is sphenoid fissure, from which the third, fourth, and what you can say the fifth and division coming out. Okay, so whenever there is any tumors which are compressing this fissure, of course there will be damage to these cranial nerves. Then there is lateral wall of cavernous sinus syndrome. Like, by the way, in ENT I talk about these things, you can correlate. Then there is retrosphenoid space. Then there is apex of petrous bone problem. Then there is internal auditory meatus problem, in which like the cranial of 7 and 8 can be damaged. Then there is tumors at the cerebropontine angle, in which cranial of 5, 7 and 8 can be gone. Then there is jugular foramen tumors or pathologies, in which 9, 10 and 11 nerves are damaged. Then there is posterior laterocondylar space issues and posterior retroparotid space issues. So when you will see the anatomy, you would know like what I'm talking about, right? So guys, like this lecture, like I talk about facial nerve, I talk about bulbar palsy and pseudobulbar palsy. I know you will not understand, because to understand these things, you must understand first what is upper motor neuron type of lesion, what is lower motor neuron type of lesion. These all things are not important. No need to memorize them. If you want to memorize jugular foramen, internal auditory meatus, superior orbital fissure, and cavernous sinus. Okay, these 4 are the important ones. So simply, you know how we go, by the way. For example, whenever, for example, vestibulocochlear nerve is damaged. For example, there's a tumor called as acoustic neuroma. Hit this one. This is a tumor, which can compress the adjoining nerves, like it can compress the facial nerve, it can compress the trigeminal nerve. Okay, so we correlate the findings in this way. So, for example, if you want to, what you can say, someone, for example, is presenting with features of 7th cranial nerve damage, with 5th cranial nerve damage, and with problem with hearing in that ear, think about acoustic neuroma, because these structures are very much closely placed. Okay, closely placed anatomically, simply. So anyhow, in the next lecture, of course, we will start discussing the motor part and the sensory part. And before starting that, of course, I will first of all I will explain you different tracts of motor. The important, not all the tracts, of course, because if I will start teaching you the basics, of course, there will be no time left for the clinic. So clinical part of the neurology. So I will talk about few important tracts which are motor one. Few I will talk about few sensory important tracts. I will explain you what is upper motor neuron type of lesion. I will explain you what is lower motor neuron type of lesion. And once after explaining that, then things will start becoming clear to you. Take it as your homework, you can say. Go and watch some videos how you examine cranial nerves. Okay, open the atlas and see the functions of cranial nerves. Okay, how they are coming out from the brain, and where are the nuclei which are related, which are present. Okay, so once, like, of course, you will cover those things, guys. You would have, what you can say, a better understanding what's going on, what you can say, with you. Okay, well, like what I'm talking about. And also, like, you can say, uh, there are some short ways to remember these things, guys. There are a lot of mnemonics available in neurology to remember the things, of course, because it's hard for, like, to remember, like, for everyone. It's not like this, like everyone can remember like everything about uh, all the things. So of course, like, you have to take remember a lot of mnemonics to remember a lot of things. Anyhow, I will see you guys in next lecture, and I hope so, like, things will start becoming clear from the next lecture about about neurology, because, like, all the sessions which to whom I teach neurology, of course, face to face, not online lectures. I try to make, like, explain the things in more practical way. Okay, so that, like, there should be better understanding of the things. So thank you so much for listening.